Cool. All right, so we're going to be jumping into the ABG worksheet. So again, a couple of things, just in case I didn't mention it, right? Why are ABGs going to be important to you guys? More immediately on Monday.
It's a short answer on the exam.
Yeah, this is what you can expect for the exam. These are your short answers. Not like this, but different numbers. Okay, so please make sure you know how to do these. Okay. So first step, what is the first step when it comes to solving any of these?
Writing out your values.
Yep. So will these values be provided for you on the exam? No. So please make sure you guys know these. Okay. I'm just writing it down here, just so that we don't have to write it for every single one. It's me being lazy, sorry. I'm still feeling pretty terrible. If you can't tell, I still look like shit. All right, so patient number one. What's going to happen is I'm going to go through and I'm going to see if I can solve this, and then we'll compare answers. If you have questions about on a specific one about when we're sorting things, just please feel free to speak up if you didn't know where to sort it or if something was different. Okay. See, so pH I get over here, CO2 is over here, bicarb is here. So for patient number one, I get respiratory alkalosis with no compensation. Agree? Disagree? Questions? Sorting?
So I have a question about how to figure out whether there's compensation or no compensation.
Yep. Okay. Sorry, I had to turn up the volume here so I can hear you.
Yeah. So when it's no compensation, is it when either of the values are neutral?
Correct. The way I personally kind of read this, you are basic because your lungs are failing you. So whatever's connected to pH. So that's why it's respiratory alkalosis. Question is, what are your kidneys doing about it? If it's neutral, it's doing not a goddamn thing. So therefore, no compensation. You are dying and your kidneys are not doing anything to help. All right, so patient two. Yep. Oh, did I not unlock yesterday's quiz? Yeah, oops. Yeah, I'll totally unlock both quizzes there. I'm sorry. I'll do it during break so that way you guys can check it out. I chances are I didn't. I was just so out of it yesterday. But yeah, thank you for the reminder. With this one, it's kind of tricky because bicarbonate is right on the edge there. So if your value is right on the edge, which column do we sort it in?
Neutral, but the arrow points towards basic.
That's only for pH.
Okay.
Only for pH. Yeah, you're correct though. So that's going to go right in that neutral column there. Okay. So for this one, I get respiratory acidosis with no comp. Agree? Disagree? Cool. All right, so let's see. 7.46, 37. Bicarb. So this one I get metabolic alkalosis with no comp. Agree? Disagree? Cool. Again, if any of you guys have questions about any specific ones, please let me know and we can kind of go through it. All right, so pH is 34. Let's see, CO2 is 30. Bicarb is over here. So now it's a little bit different. Let's see, we got metabolic acidosis with partial comp. So why is number 4 partial comp, but number 3 is no comp?
Because the pH isn't neutral.
Yeah, exactly. The pH is not within that operational range. So we're still dying, right? My kidneys are failing. My lungs are helping now. They're on the other side, but they're not helping enough. All right, so a couple of different ways we can go about this. This pH right here, that is right within operational range. So what do we instantly know about this patient?
That there's some sort of compensation.
How much compensation if they're still operational?
Full.
Yeah, exactly. So if you wanted to shortcut it, you can. I don't like to do it, but some people do. So you instantly know that it's full compensation because we're within that operational range. This person is operational. Okay. So looking at pH here, 7.38, they're technically to the left of that ideal set point. So they're technically acidic, but they're acting like they're neutral. CO2 over here. Bicarb is over there. Therefore, I get metabolic acidosis with full comp. Agree, disagree, problems, questions? All right, so last patient here. 7.44. Okay, well, ooh, that's kind of nice. That's within operational range. So we know that this is going to be full comp. Okay. But let's just, for the sake of it, kind of sort things out here. So we know pH is slightly basic, but they're acting like they're neutral. CO2 is over here. Bicarb is over there. Therefore, we get respiratory alkalosis with full comp. Questions on any of these, or anybody want me to rework any of them?
Can you upload this document to Canvas? Possibly with your right.
You want the answers, you mean?
Yeah.
Yeah, sure. Sure. I'm just gonna save it before I forget. Otherwise, I'm just gonna close out of it and then the answer will be no. Any final questions? If you're looking for more practice, don't forget that there is that website at the top. That website also is it gives you the answers, like it'll give you the problem and then you can hit like reveal answers. And if you hit refresh, it generates random numbers for you. Okay, so plenty of practice if you want it. Again, make sure you know how to do this because this is that short answer on your exam on Monday. Also remember with this one, there is no partial credit. It's all or nothing. Okay, you gotta get the whole thing. All right, so. Nope. There we go. All right, so I know you guys, your exam for health assessment's Thursday, right? Okay. So just a little bit. Now things are kind of like getting up to speed for the quarter where things kind of like hit back to back. Okay. So talking about exam 2 for patho, that's going to go down for you guys November 1st. Okay, 75 minutes for the exam, so that goes until like 9:45. So standard stuff, 75 minutes, one question at a time. No backtracking. And one attempt. Topics for exam 2. Neurophys, neuropatho. And then the big one is the fluid electrolyte pH balance. Questions? I have no friggin' idea. I don't know if you guys can tell, but you know, I'm a little sick. So I haven't written your exam at all. It's probably gonna happen tomorrow or Friday. So this is a very rough approximations. 35 multiple choice, you're looking at like 5 short answer. Yeah, something along those lines, like nothing too fancy. I don't think there's going to be an essay for this one. Yeah. Again, just to impress the fear of God in you guys, what's your short answer going to be? Yep. Okay. Questions about exam 2?
For the neurogen disorders, for the symptoms of like Alzheimer's and Parkinson's, are we doing like what the patient would exhibit or like more of the signs?
Sorry, can you mind elaborate on that question there? Like, I mean, basically, I'll just straight up give you an example. So I could say, which symptom is associated with Parkinson's? Muscle weakness, muscle rigidity, forgetfulness, respiratory depression. So kind of like that. Yeah, so just in terms of like, be familiar just kind of with what was mentioned on the slides there, kind of what was underlined. If I didn't underline it, don't worry about it. Does that answer your question there?
Yeah, thank you.
Yeah.
So yesterday you said during the lecture that fluid electrolyte balance would be 50% of the exam. Is that true still?
Yeah, just because it's all your short answers. That in combination with like the multiple choice, yeah. Just because it also ties into that neurophys when we're talking about like hyperkalemia, hypocalcemia. So that I would say like, yeah, it makes up about 50%. Okay. All right. If you guys have any other questions as we kind of go through it, just let me know. All right, so now we are going to be beginning pulmonary phys. Thankfully, this is probably one of the shortest lectures of all the entire quarter. This is kind of like our moment to breathe, no pun intended, before things get heavy again. So really with pulmonary phys, there's only two really kind of tricky topics throughout this entire lecture. And I promise we'll slow down for them, but thankfully this is one of the more straightforward ones. Okay. What are the three most important structures of the respiratory system? So don't overthink this. Why do you need lungs? Don't overthink it.
Gas exchange?
Yeah, perfect. Why do you need the muscles of respiration, i.e. the diaphragm?
To move air in and out.
Nice, yeah. So you can say to actually move air. I will go more into it, but I'm going to say to create differential pressures. Okay. And then the brain. Why did the scarecrow need a brain? To tell us to breathe? Like I said, don't overthink these. Okay. So here is your respiratory system. We're going to talk about the important structures that you need to worry about. So just an overview. Okay. Another picture of your respiratory system. Hey, did you know your respiratory system is divided into two parts, the upper and the lower? Okay. So this slide here, this is the anatomy you need to worry about. Okay. So we have this line that separates the upper from the lower. Okay. So nasal cavity, pharynx, larynx makes the upper. Lower is comprised of the trachea on down. So let's say patient has inhaled a cough drop in a coughing fit, and it is now lodged in the trachea. What kind of obstruction is that, upper or lower? Yeah, lower. So that's what you kind of need to know about in terms of this anatomy here is if I describe an upper respiratory tract infection, it could be in the nasal cavity, the pharynx, or the larynx. If I talk about something in the lower tract, trachea, bronchi, lungs. Okay, so just have kind of a working anatomy. I'm not going to be testing you outright on it. So your respiratory system, we got mucus. That mucus coats and protects underlying cells. In addition to protection, the mucus has other purposes, i.e., so definitely protection, cool. Immune support. So yes, the mucus that you produce helps capture debris. It also helps prevent bacterial infections. Why? What is present in your mucus that helps protect against bacteria?
Is it IgA?
It is IgA, very good. It is also a lubricant to help move things into the GI tract. It is a lubricant that helps move things down, but as well as up. So it allows for regurgitation or emesis. So again, if I'm choking on a cough drop, that mucus will allow me to hopefully cough up that cough drop. All right, so breaking it down here, nasal cavity, pharynx, larynx, they make up what? Upper tract, trachea, bronchi, bronchioles, alveoli, technically your lungs, sure. They make up the lower tract. Okay. One structure I want to highlight right now is the bronchioles. They are known as the primary reactive airway. Primary reactive airway. And I promise to explain why. Okay. The pleura kind of sits outside. That's just the covering to the lungs. Okay. All right, so starting at the top, your nasal cavity. Okay, your nasal cavity does three things. It does three things to incoming air. Anybody know what those three things are?
It warms it up, right?
Warms.
Filters, maybe?
Yeah, all of those annoying little nose hairs. Honestly, anybody who can pull out their nose hairs without tearing up, don't trust them. They're serial killers, okay? Warms, filters, and the last one is humidifies. Now your mouth, you can breathe through your mouth as well. However, what function does your mouth lack compared to your nose?
Humidifier?
You still have saliva, so that helps humidify it. So the mouth actually does helps humidify.
It's filter.
Filter, yeah. So your mouth does not filter incoming air. So ideally, which way or which method should we use to breathe? In through our nose or through our mouth? Ideally, you should be breathing through your nose. Fun fact, Colorado, I don't know, this is just a self-study. Colorado, I believe, has the highest percentage of nose pickers. Anybody from out of state? Okay.
Yes.
Next time you guys go driving and you're on the highway, count how many people are digging for gold in their nose. Colorado has the highest percentage, is my guess. Why? Why are people ice fishing in their noses in the morning?
Probably because it's really dry.
It's so dry here. Yeah. All right. Moving on to the pharynx. With the pharynx, the only structure you need to worry about is the epiglottis. Okay. Your epiglottis. This is kind of like a physical switch. Switch between swallowing and breathing. Okay. So your epiglottis is actually a flap of cartilage. It has two positions. It can be up or it can be down. Okay, right now it is pointed up. Okay, therefore, right now, if it is in the up position, are we breathing or are we swallowing?
Swallowing.
So if I swallow something, let's say, I don't know, I'm gonna keep going with the cough drop just because they're staring at me right now. This cough drop can go down into the stomach, no problem. But it can also go into the trachea. So do we want to swallow while our epiglottis is up?
No.
So with its up, that's going to be for breathing. Okay. If the epiglottis points down, it's covering the trachea, so that way food just goes only into the esophagus. So that one is going to be swallowing. Okay. Now I want you guys to notice here, there's a bunch of muscle fibers that control your epiglottis here. What happens to the ability to control our muscles as we get older?
It's worse.
So as we get older, what risk is now more significant?
Choking on everything.
Yep. So as we get older, our motor control isn't as great. So therefore, risk of aspiration happens in older adults. What other population is aspiration a big concern for?
Infants.
Infants, why?
I'm assuming because it's not developed enough yet.
Perfect. Same reason, they just don't have great motor control. Absolutely. Very good. Okay. So, just highlighting the fact your epiglottis, again, is this flap of cartilage. Okay, your larynx. So this right here, these are your vocal cords / voice box. Okay, so you have these two flaps of muscles in your larynx. How that kind of works is you move air past these muscle flaps. The tighter you make them, the higher the pitch. The looser you make them, the lower the pitch. Now, all you need to worry about, if a patient has a respiratory tract infection that affects their voice, what structure is most likely inflamed?
The larynx.
Perfect. Therefore, is that an upper or lower tract infection?
Upper.
Exactly. That's all you need to worry about. Basically, you're going to use this as nurses. You're going to use this to basically figure out where the inflammation, where the infection is. Again, if it's altering their voice, you know it's in the larynx and you know it's an upper respiratory tract infection. Okay, very good. All right. Now the trachea. Notice your trachea is made up of these rings of cartilage. Why? Why does the trachea, why does the trachea need to be rigid?
So that it stays open so you can breathe.
Perfect. To resist changes of pressure. Okay. So think about your cheeks. Okay, if you were to close your lips, there's no rigidity to your cheeks. If you close your lips and you blow, what happens to your cheeks? They pop out. If your trachea was soft and you want to exhale, your double chin would become a quadruple chin. Okay, you would look like a frog. And then if you inhale, it shut itself. You can't actually inhale anymore. Okay. Fun fact, your trachea is rigid, not for protection. Don't think that it's for protection. If someone's going to punch me in the throat, it's going to hurt. Anybody know how much pressure it takes to collapse the trachea?
I'm assuming not a lot.
Not a lot. Again, you don't need to write this down. This is just a PSA. It takes approximately 5 pounds per square inch to collapse the trachea. So look at the pad of your index finger. Okay, that is about a square inch. If you can apply 5 pounds of pressure with the tip of your finger, that is enough to collapse someone's trachea. So why am I telling you this? Back in the day, me and my sister, me and my sister used to teach martial arts. My father still does. I don't anymore. Y'all need to be aware of who you are and where you're going to school. Okay, Denver is a fun city, but it also can be very dangerous. Please be careful out there. Please be vigilant. Please watch out for each other. Okay, you never know when something happens. This is just a PSA. So my sister went to Fort Collins. She went to CSU. She was sexually assaulted and almost raped outside of her dorm in broad daylight. Okay. The fucking asshole kind of got what was coming to him. She broke his nose and actually caved in his trachea. Yeah, I couldn't be so proud of her. She calls me crying on the phone, like, I just killed somebody. The cops are going to arrest me. No, not at all. Okay. So please, y'all, what I'm saying is if your life is ever on the line, okay, eyes, knees, throat. Those are the 3 things you go for. Can't chase you if their leg's broken. Can't hurt you if they can't see. Can't go after you if they can't breathe. Okay. When it comes to sexual predators, a lot of them will wear athletic cups before attacking people. Okay. So just, hey, please be careful out there. Okay. It's downtown Denver. Have no mistake about that. Like, thankfully for you guys get out early enough in the day, but I have a cohort that doesn't get out till 6:30 at night. Daylight savings time is coming up. Okay, so just please watch out for each other. Be smart. Just avoid those situations altogether. Yeah. It's like I kind of care about you guys, and I don't want anything to happen to you. Okay. All right. So I know, sorry, serious PSA moment there. All right, now we're going to be talking about the bronchi. So bronchi is a split right here. You have the right and the left. Where does choking primarily happen? So what I'm trying to say is, if I inhale a gigantic cough drop and it goes down into my trachea, which bronchi is it more likely to enter, the right one or the left one?
I think it's the right.
It is the right. The right bronchi. Why?
It's shorter. Might
Kind
be-
of. So in your right side, you notice you have 3 lobes to your lungs. It has a larger diameter. So by essence, it is shorter, but just because it's a bigger hole, it's more likely to fall in there. And it is more vertical than your left one. Your left one kind of has this more of an angle to it. So if someone's going to aspirate on something, it will most likely get lodged in the right bronchi. Okay. Fun fact, does anybody know the number 1 thing people choke on?
I'm gonna guess gum.
No, it's got to be more high. It's actually higher class.
Steak.
Steak. Steak is the #1 thing that people choke on. Crazy. Thankfully, I'm a teacher. I'm not in that tax bracket. Not a risk for me. There was a crazy case it was in China. Excuse me. A man was eating vegetables and a bean sprout had managed to land inside of his right bronchi. It actually ended up growing. That guy was actually growing a little bean sprout in his lung. It seemed like chronic bronchitis, and then they did the x-ray. It's like, oh, look at that. So just chew your food, people, okay? All right. Next up on this slide, the bronchioles. The bronchioles. Does anybody remember the other name for them? Primary reactive airway. Okay. Now, I want you guys to take a look at the bronchioles here. What do the bronchioles have that none of the other structures have had yet? What do the bronchioles have that none of the other structures have yet?
Blood vessels.
Muscular tissue.
Blood vessels and interweaved with
Muscular.
muscular tissues. Yeah. This right here, that's why we call it the reactive airways. Anytime you see eoles, that indicates the presence of smooth muscle. That indicates the presence of smooth muscle. So, do you have control over your bronchioles? No, not voluntary control, involuntary control. Okay. So, if I'm allergic to peanuts and I feel my throat closing up, what structure is actually closing up?
Bronchioles.
Yeah. So I'm going to say like histamine. Okay. So kind of going back to it, I'm allergic to peanuts. I eat a peanut. My throat is closing up. Is it beneficial to cut a hole in my trachea to stick a tube down there for me to breathe? Would that help?
No, because that's not where you're experiencing the constriction.
Exactly. This is why we don't just trach patients with anaphylaxis. The problem is it's down in the lungs. Very good. Okay. So again, just having that functional anatomy there. Your bronchioles, that's the lower respiratory tract. Okay, that's why we rely on epinephrine instead. Next up are your alveoli. This is where we finally see that gas exchange. Okay, notice each alveoli sac has its own bed of capillaries. Its own bed of capillaries. Therefore, you can hold a lot of blood in your lungs. Any given point inside your lungs is 30 to 40% of your overall blood. All right, so lungs, you got 3 lobes on the right and 2 on the left. Why? Why don't we just have 3 on both sides?
To make room for the liver, right?
A little higher than the liver. The liver does play a role, but there's something else.
The spleen. I don't know.
Yeah. On the left here, very close. This is to make room for the heart. Mhm. So you had it. I think you were just overthinking it. Fun fact, you don't need to write this one down. Each lobe can hold, give or take, about 1,000 milliliters of air. So Alexis, I'm going to pick on you because I think I saw your Nalgene. You got a Nalgene on your desk? You mind holding that up really quick? That is a liter. You have 5 lobes. So in theory, you can hold 5 of those inside of your lungs. Thank you. That's crazy. Can you use all 5 liters though? Can you use all 5 liters of space? No, your lungs don't completely collapse, okay? All right, so serous membranes, okay? What happens is this fist represents an organ. A serous membrane is 2 layers of membrane, and then there's this lubricant in between those 2 layers. So question then, what is the purpose of serous membranes? Why would I need to surround an organ with lubricant?
So that there's no friction on it.
Nice. Purpose is to minimize friction. So you do not need to do this math. You are not responsible for doing this math. I just want you to appreciate yourself, appreciate your body, okay? So tying into health assessment, in terms of vitals, what is typical respiratory rate? What is that range?
10 to 20.
10 to 20. So let's assume that you're all extremely healthy. Let's say that we take 10 breaths. Okay, per minute. 10 to 20 breaths per minute, right? So give or take, that's what? 600 breaths per hour. By the end of today's lecture, you're going to take, I don't know, about 2,000 breaths in 3 hours. Now, if you're to take this and multiply it by, at least the hours, multiply by 24. Assuming that y'all are stupid healthy and you're only taking 10 breaths a minute, you're taking about, give or take, 15,000 breaths per day. Anyone ever think about that? That's freaking crazy. If you were to rub your hands together 15,000 times, what's going to happen? It's okay, I got thick calluses. I'll wait.
It's gonna get hot.
It's going to get hot, and what's going to happen to my skin?
It's gonna rub away.
Exactly. So these right here are super, super important, okay? If you're going to do something 15,000 times per day, you don't want any friction. So 3 places where we need to minimize friction. Definitely respiratory. What else? What other organs see a lot of movement?
The stomach.
I'm going to say your GI tract.
The heart.
The heart. Awesome. Those are the 3 places. Ta-da. Okay. So now we're going to be talking a little bit about the pleura, the lung coverings here. What I want you guys to notice is you guys notice that there's this gap between the pleura and the lung. Okay. This gets into pressures. So remember when I told you at the beginning of this lecture, there are 2 kind of concepts that are a little bit tricky. This is one of them. Okay. So when it comes to pressures, what I'm doing here is this is your chest cavity. Really, it's your pleura. And then here is your lung. This is kind of like a sideways view. Okay. You can kind of think of it like a taco. In your chest cavity, there are three pressures. First, we have P sub A or PA. Then we have PB. And then that space in between, that is called PIP. So just to kind of actually define these, PA, this is the alveolar pressure. So this is the pressure inside of your alveolar sacs. Okay. PB, this is barometric pressure. Barometric pressure. Okay, so just the atmosphere, the environment. And then PIP, P sub IP, PIP, that is intrapleural pressure. Side note about PIP. Okay, PIP must always be negative. In healthy people.
If the if the PIP is positive, is that like a pneumothorax?
And we'll talk about those more specifically with pulmonary patho. But the idea here, and I'm just going to elaborate on that. If I get stabbed in the chest, okay, let's just say Kendall decides to take it out on me. That's fine. Kendall stabs me in the chest. What happens to my lung?
It's gonna collapse.
It's going to collapse. What I'm getting at is that PIP is always negative because it's always pulling on the lung. Why would I want to always be pulling on the lung? What's that going to do to my lung?
It's going to keep it open.
Must always be negative in healthy people in order to keep lung inflated. Very good. Now, on top of all this, law of gases. Gases only ever move from high pressure to low pressure. Okay. So take for example, if I have a can of soda and I start shaking the living crap out of it, I give it to poor Ariona. What's going to happen when she opens the can? It's going to explode. Why? The pressure inside the can is very, very high. The pressure in the atmosphere is low. You crack that can, that's why the beer explodes outward. Okay. We good with this in terms of knowing what these three pressures are? Okay. So taking a look at this here, you need to tell me which pressures are the biggest and smallest for inhalation and expiration. So what I recommend is you draw a picture. Always draw a picture. Here's PA. Here's PB. Here is PIP. So during inhalation, am I bringing air into my lungs or out of my lungs? So that means I'm going from the outside into my lungs. You agree? Now, gases only move according to the pressure or from high to low pressure. So therefore, looking at this here, during inhalation, what's going to be higher, PB or PA?
PB.
Yeah, so this is the way I set it up here, is I kind of think of from high to low, must go from PB to PA. That means during inhalation, PB must be bigger than PA. So what does that mean? In inhalation, or I should say with inhalation, you need to drop, you need to lower the pressure in your lungs to bring that air in. Question for you. Where does PIP go in this equation, left or right?
Wouldn't PIP be higher because it needs to actually help inflate the lungs?
This is where it kind of gets a little
Or is it the
counterintuitive.
opposite?
Yeah. It's the opposite, because in a healthy person, PIP should always be what?
Negative.
So what's worse, high balance, low balance, or being negative? Yeah, so you are right if you're looking at like absolute pressures, but just because it's negative, it's lower than low. So during inhalation, what is the largest pressure?
PA.
Largest, highest?
PB.
Yeah, it should be the barometric pressure, high to low. Okay. How do we feel about this so far? Now, would it be possible for me to rewrite this as such? Does that second equation hold true? Yeah. So let's think about nightmare situations here. If I were to give you a multiple choice and you had 4 of these stacked on top of each other, where's process of elimination going to go? Okay, so what I'm getting at is learn how to solve these, because the science can definitely throw things off. Okay, again, always kind of start with where are you coming from and where are you going. Okay, so let's try to give you guys some practice here with expiration. There's your chest cavity. Here's your lung. PA. PIP. And PB. Gases only move from high pressure to low pressure. So give you guys a couple of seconds there. I want you to write out the equation for expiration. Let me know what is going to be the largest pressure for expiration and what is going to be the lowest pressure for expiration. Okay, so let's take a gander here. With expiration, Where am I moving air from and where am I moving air to?
Inside to outside.
Yeah. Okay. Therefore, which one has to be higher, PA or PB?
PA.
PA, exactly, because we only move from high to low. Why is PIP always the smallest?
Because it always has to be negative in healthy people.
Always has to be negative. Awesome. So if you guys notice, PIP is always the smallest for expiration and inspiration. Questions on this one? Okay. I'm just trying to see where we're at. All right, so this might help. I'm not entirely sure. This is just kind of hopefully to help visualize kind of what's going on here. Okay. So you might have done this experiment back in grade school when you're trying to like do different science project fairs. Here's this Coke bottle represents your chest cavity. Okay, the clear plastic, those are your ribs. Pink balloons, your lungs. What about the space inside the Coke bottle? What would that be?
Your pleural cavity.
Yeah, that's the pleural cavity. And what pressure do we find in that empty space?
Negative pressure.
Yeah, that's PIP, which is negative. Exactly. So you guys can kind of see the lungs. Here, PIP isn't entirely negative. That's why the lungs aren't inflated. Okay. Pulling down on the orange balloon. So that's your diaphragm. Your diaphragm pulls down. When your diaphragm pulls down, air is going to come from the outside in through the airway into the lungs. Gases only move from high to low. So during inhalation, PB is high, flowing down to the low pressure in the lungs. PB is higher than PA. I contract, all right, I relax my diaphragm, PA is large, that's going to push the air out into a lower PB. Does that kind of help to actually like have a visual going on there? Okay, so you're constantly changing the pressure between the two areas. 15,000 times a day, give or take. Awesome. So let's take a little break. Let's say like 10 minutes. So like 9:23, we'll pick back up again. I will unlock those quizzes, by the way, so that way you guys can check out the questions and the answers. Okay. Let me know if you need me to go back to a slide or anything like that. All right. Okay. So, in terms of mechanics for breathing, really, there's only a couple of muscles I need you to focus on. So the diaphragm is the major muscle for inspiration. Okay. Diaphragm is the major muscle for inspiration. You do not need to worry about the ribs. I'm not going to ask you about that. Okay. I don't really care about the rib muscles. So with the diaphragm, when it contracts, that pulls on the lungs, dropping the pressure, bringing air in. Okay. For expiration, for forced expiration, that is the rectus abdominis. Again, don't care about the ribs. So forced expiration, this is what you use to kind of blow out candles, etc., fire, spit wad, whatever. Question for you then. What muscle do you use for just regular expiration?
You don't use muscles because it's, excuse me, you don't use muscles because it's just going by the pressure.
Yeah. Think about your lungs being elastic, right? You stretch a rubber band, it wants to come back. So really, it only takes energy to inspire. It doesn't take any energy to expire. So same question if I flip it, what about forced? Oop. There we go, forced inspiration. Okay. If you use your diaphragm to inspire, what do you have to use to inspire harder? Don't overthink it. If you use your diaphragm for regular inspiration, what do you have to work to inspire harder?
The diaphragm?
Yeah, still the diaphragm. Okay. In health assessment, you'll get into the accessory muscles, but for me, I try to keep it simple. I don't want to make anatomy more complicated than it should be. Okay. So, hey, cool, diaphragm, rectus abdominis. Okay, so ventilation. Now, I know this is going to sound very simple, but students kind of forget this all the time. Okay, ventilation is the mechanical movement of gas. Whenever you see the term ventilation, let it be a keyword. Whenever you see ventilation, that means moving gas or air. Okay. Whenever you see ventilation, it just means we're moving air. Okay. Minute volume. You don't need to know this calculation until like MedSurg 1. I'm just going to be explaining this. Minute volume is going to be your respiratory rate multiplied by your tidal volume. Okay, so tidal volume, this is just the amount of breath that you take in typically. Nothing too great, nothing too small. This is just what you're using right now. So if you were to figure this out, this is breaths per minute multiplied by the volume you breathe. Breaths cancels out, volume per minute, that's your minute volume. Again, don't worry about this calculation. You're not gonna have to worry about it until MedSurg 1. That's just how you calculate it. Alveolar ventilation. So using this keyword ventilation, this is just defined as moving air at the alveolar sacs. Okay. Again, don't worry about minute volume. I'm not going to ask you to calculate it. Take away from the slide, just ventilation means moving gas. Okay. So your alveolar sacs, they secrete surfactant. Surfactant has four purposes here. Yeah, I would probably know these four. Okay. One of them is to decrease surface tension. So at your lungs, decreasing surface tension. Good thing or bad thing?
Probably a good thing. I don't know.
Yeah, absolutely. It's definitely a good thing. So if your lungs are super tight, imagine the opposite. If your lungs are super tight, does it become easier or harder to breathe? It's kind of hard to breathe, right? If your lungs can't stretch. So if you decrease surface tension, that's going to decrease the work of breathing. Another thing that it does is antibacterial. Antibacterial. Why? What would be present in, I don't know, a secretion? Sorry, what would be present in a secretion to help you fight bacteria? IgA, beautiful. Next thing that does is it helps repel, ooh, that came out terrible. It helps repel water. It helps repel water. Okay. So, can you still drown? Yes, absolutely. Okay, but if you go out in the rain and there's a lot of humidity and you're inhaling that humidity, do you instantly get pneumonia? No. We repel water, therefore that helps prevent pneumonia. And the last thing is it prevents the collapse of your alveolar sacs. It keeps your alveolar sacs open. Okay. Why is it so important to keep your alveolar sacs open?
So that you can perform gas exchange.
Absolutely. That allows for that gas exchange. Okay. So 4 properties to surfactant, you should probably know them. All right. Now, in terms of the elastic properties, there are 3. Elastic recoil. This is the ability to return to original size/shape. Compliance, this is the ability to stretch or deform. The last one is resistance. Resistance is the ability, you can say the ability to resist, that's fine. I just don't like using the same word in the definition. So I say the ability to withstand, stretch, or deformation. Okay, so kind of working with this a little bit, I want you to think of a rubber band. Rubber band. The elastic recoil of a rubber band, is that high or low? Does the rubber band have the ability to return to its original shape/size?
I want to say, but it like depends on how hard you stretch it, really.
And
Just, yeah, I mean, let's assume that we're not abusing it. Let's just say we're using it within normal limits. Good point. So would the elastic recoil be high or low of a rubber band?
It would be high.
It would be high, absolutely. What about the compliance of the rubber band? Is a rubber band very compliant or not so compliant?
It's not, you can stretch it, but it always wants to return back
Mhm.
to its
How hard
original.
is it to stretch it? Do you need to use like 2 fingers or do you need to like bear down with both hands to stretch it?
Depends on the size of the rubber band, but normally just a finger would work.
Yeah, no, you guys are definitely getting the hang of my trick questions. Sorry, I'm making you so paranoid. Okay, how about instead of a rubber band, we just talk about a scrunchie? Huh? Let's talk about scrunchies. Those are a thing. They're coming back. So a scrunchie has high elastic recoil because it wants to go back. Compliance, it's very compliant. It has a high compliance because it has the ability to stretch. What is the resistance of a scrunchie? Does that scrunchie really want to fight you?
No.
No, correct. So a scrunchie has a low resistance, okay? Excuse me. Okay, let's think about a table. Assuming that you guys are running on a table right now. Does your table have high or low elastic recoil?
low,
Pretty low. What about the compliance, high or low?
low,
Low. Yeah, can you stretch your table? I hope not. Resistance of the table then, high or low?
high,
Exactly. That's why you guys write on the table. So applying this now, what are your ideal, what are your ideal lung properties? In an ideal lung, do you want high or low elastic recoil?
High.
Mhm. Compliance?
High.
Mhm. Resistance?
Low.
Yeah, very good. Okay. Airway resistance, this is just the difficulty of moving air. All I'm going to say is keeping it very simple. These should be low. Okay. Do you want it to be hard to move air through your respiratory tract? No. Work of breathing, if you have to do something 15,000 times a day, do you want it to take a lot of energy? No, right? All right. With this slide here, all we're going back to is the brain stem. Brain stem is responsible for what?
Vital reflexes.
Perfect. So breathing is a vital reflex, yes? Breathing controlled by the brainstem. Don't need to worry about these two. There are some chemoreceptors, central chemoreceptors, central, think central nervous system. This is in your brain. Your brain can detect CO2. Excuse me. Now, reviewing from yesterday's lecture, human body is mostly made of water. What happens when you combine CO2 and water? What do you get?
Bubbles.
Yes, bubbles. And in terms of pH balance,
An acid?
an acid, yeah. So if you can detect CO2, you can also detect protons. Perfect. Peripheral chemoreceptors. So the peripheral ones are located in your heart. They detect CO2, therefore they can also detect acid, but they can also detect oxygen. That's weird. This is one of the few situations where your heart can detect more things than your brain. Why? Why would it be able to, why is it important to detect oxygen at the heart instead of the brain?
Because deoxygenated blood flows into the heart and needs to be oxygenated again.
Exactly. Who gets blood first, your brain or your heart?
Your heart.
Mhm. If there's a problem with oxygen, we need to know at the heart. If we figure it out by the time it gets to the brain, it's too late. Can't fix anything. Very good. So just showing you your peripheral chemoreceptors detect all three, while your central chemoreceptors only detect two. You got to fix it at the heart before it goes to the brain. Nothing really too crazy here, except just reiterating bronchioles. What do you instantly know about bronchioles?
They're the primary reactive airway
Why?
because they have smooth muscle.
Nice. Primary reactive airway due to smooth muscle. Whenever I see these kinds of pictures, I just, can you imagine being the person who had to dissect that, who had to cut that out? That's insane. If you ever get a chance to see the Body Worlds exhibit, highly recommended. Okay, so this slide here, don't overcomplicate this. Okay, don't overcomplicate this. Instead, I want you to use this more as vocabulary, like trigger words. Okay, ventilation. What did ventilation mean?
The movement of gas or air.
Perfect. I'm going to say move air. So when it comes to breathing, there's 4 steps. Step 1, ventilation of the lungs, i.e. step 1, move air into your lungs. Easy enough. Second keyword here, diffusion. This is still moving air. If we're talking about diffusion, moving air, but this is on the cellular level. Okay, so diffusion. With breathing, step 1, move your air into your lungs. Step 2, take the air, stick it onto a red blood cell, cellular level. Step 3, you guys remember, what does perfusion mean?
The movement of oxygenated blood. Sorry.
Yeah, it sounds like you got what I got.
I think
Perfusion is going to be moving blood. Perfusion is just talking about blood flow. Finally, diffusion. Again, just moving air. Cellular level. So just recapping this. How does breathing work? Step 1, bring air into your lungs. Step 2, take the air from your lungs, stick it on a red blood cell. Step 3, move that blood cell to wherever you need it to go. Step 4, take the oxygen from the blood cell, give it to the tissue. Okay. Just use this slide really more for the key terms here: ventilation, diffusion, and perfusion. No, I use that. CO2 just happens in the reverse order. Take CO2 from your tissue, stick it on your blood cell, move your blood cell. Take the CO2 off of the blood cell, move it to the lungs, get rid of it. All right, so gas exchange happens across the alveolar sacs. There are two types of alveolar cells or alveoli. Type 1. Okay, so personally for me, this is the way I kind of think of it. Your type 1 alveolar cells, they do the primary function. What is the primary function of your alveolar sacs?
Gas exchange.
Beautiful. Type 2, they do the secondary functions. That is surfactant. Again, just recapping, how many functions of surfactant were there? 4. And yes, you do need to know them, okay? Another name for your alveolar cells, just in case you see it later, you can call them type 1 alveolar cells or type 1 pneumocytes. Pneumo, if you're curious, that means air. So your air cells. Okay. All right, cool. The only point that you need to worry about is this first one here. Pulmonary circulation has a lower pressure than systemic circulation. Don't worry about those. Okay. Pulmonary circulation has a lower pressure than systemic circulation. We'll talk about more about that when we hit cardiophys. All right, your alveolo-capillary membrane. So this is the membrane between your alveolar sacs and your capillary. In fact, they share a wall. This is just going to basically, they share a wall to facilitate gas exchange. So kind of think about if you have to pass air between your alveolar sac and your capillary, do you want 2 walls or 1? 1 wall just makes it easier. Membrane is formed by the thinnest of cells, that is the simple squamous. Epithelial cells. Okay, really that, I mean, there's not really much I can test you here. So just saying, this is your alveolar sac over here. Your capillaries next to it. Notice they only share a single wall and makes things easier to pass back and forth. That's what I was trying to get at. All right. So this slide here, let me be clear. You do not need to know these numbers. You do not need to know these numbers. Instead, I want you to be more aware of why things are happening. So recapping, gases only move from what to what? What is that law?
High to low.
Perfect. Gases only move from high pressure to low pressure. So oxygen. Talk about oxygen. Where do you want oxygen? In the environment or in your tissue?
In my tissue.
In your tissues. That means if you want it in your body, you want to go from the environment to the body, the pressure of oxygen at the body, does that have to be higher or lower than the environment?
Lower.
Exactly. So taking a look, the environment is give or take 160. Your tissues is 40. So you're going from give or take 160 to 40. That makes sense. Okay, what about CO2? Do you want high or low pressure at your body for CO2?
High.
We want to go from the body to the environment. Therefore, 46 to 28. Again, you don't need to know the numbers, just understand gases only move from high to low. So why? Why does CO2 go from my body out into the environment?
Because at too high of a level, it becomes toxic because we get acidotic.
Yeah, simpler than that. It goes simpler than that. Why does CO2 want to leave my body?
Because it's a waste product
It's a waste product and gases only move.
from high to low.
Exactly. So why do we get rid of CO2? Because our pressures are higher than the environment. CO2 wants to leave my body. Okay. Why do we want to bring in oxygen? Why does oxygen just naturally go towards our tissue?
Because our tissues have a lower concentration.
Or pressure. Yeah, that's totally fine. Okay. So that's the why. Why do we want to bring in oxygen? Why do we get rid of CO2? The difference in pressures. Okay. Fun fact, you don't need to write this down. For my exercise physiologist out there, what limits athletic performance? Is it the ability to bring in oxygen or the ability to get rid of CO2? What limits athletic performance?
Isn't it the ability to get rid of CO2?
Yeah. So if you kind of think of it like a slope, you guys check out this 46 to 28. Yeah, it wants to go down versus 160 to 40. So i.e., this is just, again, a fun fact, you don't need to write about it. Our ability to bring in oxygen is great. Oxygen wants to go into our body. Getting rid of CO2, it's slower, it's harder. So, fun fact. Okay, so in terms of how do we move oxygen throughout the body? Two ways. You have your oxyhemoglobin. So that's the red oxygen attached to your red blood cell and being dissolved in plasma. Your hemoglobin moves, I believe, let me just double check here. You don't need to know the percentages, but it's just the majority. Yeah, 97% of your oxygen versus 3% dissolved in plasma. So question is, what is the primary method of oxygen transport in the body?
Red blood cells.
Done. Easy enough, yeah? CO2, there are 3 ways to get rid of CO2. We can stick it on our hemoglobin again. We can use the bicarbonate buffer system and then dissolved in plasma. My question to you guys, actually, let me kind of explain this. This only moves 23%. This moves 70%. This only moves about 7%. Why? Why do we rely on bicarbonate as the primary method of CO2 transport?
So that, you know what, never mind, I'm wrong.
You're good. You're good. Think about your exam on Monday. What's the issue about CO2?
It's acidic in the body.
It's acidic in the body. CO2 is acidic. Do proteins like acid? No.
No.
Proteins dissolve in acid. So that's why we don't use red blood cells as the primary transport. Bicarbonate. What do you guys remember about the bicarbonate buffer system? Why do we have buffers?
To buy us time.
Exactly. So if I use CO2, or sorry, if I use bicarbonate to transport CO2, will I see a change in my pH?
No.
No. Perfect. So again, that's the why. Why do we need to rely on bicarbonate? To prevent changes in pH during CO2 transport. Okay. All right. So this is the last kind of part here, the ventilation perfusion ratio. Give you guys a heads up. This is something that students typically kind of struggle with. So I say, like, let's take a quick break, run around, get your energy out. This is that last complicated topic I was talking about. Let's go for like 7 minutes if you guys are cool with that. So like 10:02, we'll pick back up again. But yeah, just heads up, this one can be a little tricky. All right. Cool. So this will be the last part here, the ventilation perfusion ratio. Okay, so ventilation perfusion ratio can get complicated if you get lost in the details. Please don't. What I recommend is always kind of start big picture. Ventilation. What does ventilation mean?
Air and gas movement.
Nice. Moving air. I'm just gonna say air to kind of keep it simple. Versus perfusion. What does perfusion mean?
Moving blood.
Mhm. Okay, so with this ratio, we're looking at the amount of incoming air versus the amount of incoming blood. Okay. So let's take a look at situation A. Okay. Whenever it comes to your ventilation perfusion ratios, always set it up as V over Q. I don't know why, but V is standing for ventilation. Q is always perfusion. Okay. So if we take a look at situation A, I'm going to zoom in a little bit here. Okay, if we take a look at situation A, notice I have 2 alveolar sacs and 2 capillary beds, one around each alveolar sac. Okay, so we're going to assume, and then you can use any numbers you want. You can use any numbers you want. Let's assume that your alveolar sacs can move 2 units of air each. And your capillaries can move 2 units of blood each. So therefore, how many total units of air am I moving in situation A?
One.
Each one moves 2, and you got 2 of them?
Oh, we're not doing the equation.
Not yet, not yet. So how many units of air are we moving in situation A?
4.
Yeah, and how many units of blood?
4.
Perfect. So looking at our ratio, we move 4 units of blood and 4 units of air. Therefore, exactly, you were right, Ashley. We move a total of, it's a ratio of 1 to 1. Every unit of air has a unit of blood. Awesome. That is what we want. That is quote unquote normal. You guys kind of see how that works? Okay. So what about situation B? V over Q. So if I take a look at situation B, notice, whoa, well, I don't know what happened there. Okay, in situation B, notice one of my alveolar sacs is a little congested, a little clogged. Does that mean we move more or less air? Should be less, right? Over here, I'm still moving 2 units of blood. Somebody give me a number less than 2. Yeah, let's keep it easy. Just say, here I only move 1. Blood flow. Now we're not looking at the quality of the blood. We're just looking at perfusion, the flow of blood. Has the blood flow changed in situation B?
No.
Nope. So it's still 2 to 2. So if we zoom out, what has happened in situation B is that my V has decreased. I am no longer moving 4 units of blood, or 4 units of air. How many units am I moving now?
3.
Perfect. Blood is still the same at 4. So my question to you what has happened to my ratio? It went from being 1 to now 3/4. Did it increase or decrease? That's why situation B, we say a decrease in the ventilation perfusion ratio. Okay. Now, situation C. Okay, without me having to zoom in here because it's kind of pretty apparent. We have an entirely collapsed alveolar sac. How much air can you move through something that's completely collapsed? None, right? So here, one of them are still good. Blood vessels are still fine. What is my VQ ratio now? So now it's 2/4, i.e. it has halved. So compared to B, has my ratio decreased more or less?
More.
That's why we call this a very low VQ ratio. So what are you guys noticing? If I have some issue with ventilation, what happens to my ratio?
It decreases.
It decreases. What about Q? If I decrease perfusion, what should happen to my ratio?
It'll increase.
Yeah, that's weird. Let's take a look at why. So I'm going to zoom in on this one because it's actually kind of hard to see. So in situation D, do you guys notice it's kind of impaired there? There's like a clog or some sort of plaque, okay, in the blood vessel. Looking at our alveolar sacs, they're fine. They're moving still 2 units of air each. It's the blood I have trouble moving with. This capillary over here is fine. This one's maybe moving, I don't know, half of what it should be. So let's just say 1. So therefore, if we take a look at our ratio, V is still fine. V is still 4. The issue is Q is now 3. So doing some fancy math. What has happened to my ratio if I restrict blood flow?
Wouldn't it be 1.25?
Well, all right, let's go correct the teacher about his freaking math.
I'm sorry, I'm just making.
No, you are totally correct. My bad. Thank you. Sorry, what has happened to your ratio now? Is it 1.33 now?
It's 1.33 because it's 4/3.
Damn it. Leave the sick guy alone. So therefore, how about I just simplify it? It went from 1 to 1.33. If we decrease perfusion, that should increase that VQ ratio. Damn it. Thanks, Greg. And I think that was Ashley. Or Noe. Okay, so why do we care about this VQ ratio? What's up with this? Take a look at situation A. Let's talk about, Lord, if I can stop dying. Okay, let's assume blood oxygen, we are completely efficient. It comes in at 0% saturation. You pick up oxygen in both alveolar sacs. What should your blood saturation be after the alveolar sacs?
Can you repeat that? That was kind of confusing.
Yeah. So let's just assume you use all of the oxygen in your blood. The deoxygenated blood coming into your lungs is 0% saturated with oxygen. Once you go to your lungs, you pick up oxygen. What should it be coming out?
100% oxygen saturation.
Yeah, 100%. I agree. That's what I was trying to get at. Sorry. So each alveolar sac does give or take like 50%. Would you agree? Okay. Now taking a look at this one, situation B, I'm not moving as much air. I have impaired ventilation. So if 0% is coming in, would we have more or less than 100% coming out?
Less.
Notice your deoxygenated blood is mixing with your oxygenated blood, so it's like 75%, give or take. Taking a look at C, we have an even further decrease. Therefore, would my oxygen saturation be higher or lower than 75%?
Lower.
And then the last one is kind of a little bit tricky. I want you to assume that we are going to divert all blood here. Let's just say that this is a clot. All blood is going to go towards this good alveolar sac. If all blood goes towards the good alveolar sac, it's going to get oxygenated, which means what's my final oxygen saturation?
100%.
It's 100%. What is going on? Your VQ ratio, what we're trying to figure out here, is another way of determining oxygen saturation. Okay, so let me zoom out here.
Is this what they do in like an ABG?
Kind of, yeah. Your VQ ratio is used to give insight into O2 saturation. Okay. We're going to still be exploring this a little bit here, but again, ventilation perfusion ratio, the ratio of moving air against moving blood. If you move less air, your ratio goes down. You move more, or you move less blood, your ratio goes up. Okay. Again, just kind of think of it as fractions. V on top as the numerator, Q is your denominator. Okay. So sorry, I should have drew this. Q decreased in situation D. All right, so what's this all about? If we detect low, if we detect low oxygen, what state do we call that? What do we call it when somebody is low oxygen?
Hypoxia?
Hypoxia. Is that good or bad?
Bad.
Bad. So hypoxia is the trigger here. Okay. If I detect hypoxia at one of my alveolar sacs, that is bad. So what I'm going to do is I'm going to shunt blood to a better alveolar sac. So let me say that this is actually super important here. This is a protective reflex. And this will provide a better ventilation perfusion ratio. I'm going to explain this a little bit here, but just saying hypoxia is the trigger for shunting, and shunting is a protective reflex. Okay, so we're going to come back to this slide, I promise. Okay, so take a look at these two alveolar sacs. Okay, one of them absolutely sucks. One of them is good. So let's assume blood coming in here, okay, let's assume that this alveolar sac cannot exchange gases. It cannot. What would be your final oxygen saturation if this sac is completely dead? 0% mixing with 100%. What would you get?
50%?
50%. Is that enough to live?
No.
Oh God, no, absolutely not. So what should we do? We need to shunt. When we shunt, we're going to vasoconstrict. So let me say shunting is a protective reflex where we will divert blood away from a defective alveolar sac. Shunting is a protective reflex where we will divert blood away from a defective alveolar sac. Okay. So if I vasoconstrict here and say no more blood goes through here, if no more blood goes through the bad alveolar sac, what's my final oxygen saturation?
100%.
That good?
Yeah.
Hell yeah, absolutely. So you guys see how shunting is protective? It helps increase your oxygen saturation. Here's the key point. It is good for now, bad for later. Good for now, bad for later. What? Again, just recapping, why was it good? What did shunting do?
Moved blood to a working alveoli so it could be oxygenated.
Perfect. It was good because it increased my oxygen saturation. Let me see my O2 set. Okay, so then why is this a bad thing? Anybody commute to Denver? I-25? How fun is that when they shut down all of the lanes into one lane? If you go from a 4-lane highway to a 1-lane highway, what are the problems you face?
Congestion of traffic.
Oh yeah. Things get crowded. Things get slower. There's higher pressure. There's road rage. What I'm saying is the reason why it's bad is I want you to imagine you have 2 hoses. One hose is defective. Now you're jamming that second hose into that first hose. If I am running twice as much fluid through one hose, what happens to pressure? If you jam twice as much fluid through the same hose, what happens to your pressure?
It increases
How much?
by 2 times.
Yeah, this doubles blood pressure at the alveolar sacs. So just hypothetically speaking, if your blood pressure is 120/80, and then I double it, what would happen if your blood pressure was 240/160?
What was the value again?
Sorry, what would happen if your blood pressure was 240 over 160?
You could stroke out.
You're going to throw a stroke. You're going to have an aneurysm. Your blood vessels are going to rupture. Hey, that's bad. Would you agree? That's what we're doing in our lungs with shunting. Good for now because, hey, you get to breathe. Bad for later because now we're going to start destroying those vessels. Scrolling back up. What triggered this whole thing? Hypoxia. Provides better ventilation perfusion. Sweet. That increases oxygen saturation. What was the problem though? Why was it bad for later?
Increasing pressure.
Pulmonary hypertension. Yahtzee. Good for now. Bad for later. So exam 3 is going to be all about cardiorespiratory. Here we have some issue in the respiratory system. We're going to get into how this affects your heart. So let's do this. Let's assume somebody has some sort of respiratory issue / pathology. Okay, so let's just say somebody has some sort of respiratory pathology. I don't know, chronic bronchitis. Taking a look at V over Q. If I have difficulty breathing, which value will that affect?
V.
V. And will that increase or decrease V?
Decrease.
Yeah, because I'm ventilating less, I'm moving less air. Therefore, with a respiratory issue, respiratory pathology, what will happen to my ratio overall?
It'll decrease.
So what I'm getting at is chronic bronchitis, emphysema, a steak, a chicken nugget, a cough drop in the windpipe. All of those things will decrease your VQ ratio because we decrease V. If we have a cardio issue / patho, that will increase your overall ratio. Why?
Because usually V will stay the same, but Q would decrease.
Correct. In a cardiovascular issue, that's moving blood. If I'm moving less blood, that's a decrease in Q. Decrease the denominator, the fraction goes up. So, shunting. Shunting does what to your VQ ratio? Does it increase or decrease your VQ ratio?
Increase it.
Why?
Because initially it starts at 50% oxygen saturation due to the non-functioning alveoli. So then when it constricts that blood vessel and it sends it to one that's functioning, it's going to increase it from 50 to 100.
Perfect. Great, great, great. I'm going to simplify it a little bit there. In shunting, are you changing the flow of air or the flow of blood?
Flow of blood.
Therefore, shunting increases your VQ ratio because we decrease perfusion. Okay. Well, we will revisit this ventilation perfusion ratio again when we hit kind of cardio as well. This right here, this is going to be for skills lab. Don't worry about it. Holy cow, good, okay. Now we're done with breathing. I'm done. Okay, so that is respiratory phys. Normally I would do a little bit of patho, but I say let's just save patho for after the exam. Still dying, sorry. Okay, so recapping, exam on Monday. You know what the short answers are going to be. Practice with that. After the exam, we'll get into respiratory pathos. Questions, preguntas? Anyone else want to correct my math? Anyone want to double check that 15,000 breaths per day? Awesome. All right, guys. Good luck on health assessment later this week. I know you guys got that coming up on Thursday. Advice for health assessment exam 1. It's not hard. The material is not difficult. What trips people up on exam 1? Not reading close enough. People will read objective and take it as subjective, or they'll misread the population, or they'll forget that, or they'll misread something that says not a sign or something like that. Okay. So with health assessment, exam 1's not too bad in terms of material. It's not heavy. Just read closely so you don't miss those simple questions. That's my biggest advice for exam 1.
How do you,
Exam 2. Oh, go ahead.
sorry, I didn't mean to interrupt you. How do you, what do you think like is the best studying, I guess, tips for this coming up exam for exam 2? Because neuro is so heavy. I'm just like, I don't really know what's the best way to study it.
For sure, for sure. So for neurophys, action potentials is going to be kind of a big thing. Like to being able to draw out that action potential. So I would say that. Sorry, I'm kind of running through it. Organizing the nervous system, sympathetic versus parasympathetic. Neuropatho, I would say almost kind of like chunk it, where, you know, like pain was a thing, large A's versus small C's was a thing. Yeah, neuropatho, you don't need to go too crazy with it. I would say just superficially chunk it into the different sections there. Then the fluid electrolyte pH balance, diagrams. Diagram out the electrolytes, so how that affects your action potential. You know, calcium versus potassium affects which part of the action, which part of the neuron. Fluid balance, know salt, know how salt moves, know how salt moves water. Reading carefully versus, you know, like hyponatremia is not the same thing as hypocalcemia. Check out that Chubby Emu video. I recommend it. pH stuff. Okay, the biggest thing that students mess up with pH, if I increase pH, does that mean I'm getting acidic or basic? If I increase pH,
Basic.
I'm getting basic. So does that mean I have more or less protons?
Less.
Less. So for whatever reason, people see pH going up. They're like, oh, protons, H goes up as well. Not the case. So it's just simple stuff with that, like with the pH stuff. The chart with the respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis, be able to recreate that logically. Don't try to memorize it. Understand what leads to what, so that way if I'm asking for a symptom, you can instantly rationalize it. If I'm asking for a compensation, again, you can rationalize it. So neurophys, try to diagram as much as you can. Neuropath, chunk it. Like I said, it's just a bunch of like random, I shouldn't say random, but it's a bunch of kind of disconnected topics. And then pH, fluid, and electrolytes, I would say if you can, try to diagram it. That's really kind of the best way. I think a picture is worth a million words. Yeah, and Quizlets can be totally helpful as well. I know students used to make those. I don't have any. That's another great study method I would also recommend is like groups of 3 to 4. I kind of think 3 to 4 is like the perfect number. Basically, you sit in a circle and then you ask each other questions. Quotes are pretty warm and fuzzy too. But basically, if you guys can get into groups of 3, like that's what I would do for health assessment and patho, is like I'll just pick on the 3 in the corner here. So let's just say Greg and Kendall and I are in one study group. I'm going to ask the group a question. What is the purpose of hyperpolarization? Greg, Kendall, they're going to write their answers down on a piece of paper. We're not sharing answers yet. Then Greg asks a question. What controls body temperature? We write down the answers. Kendall asks a question. What is the only electrolyte affected by pH? We write down our answers. We keep going in a circle until we get to like, I don't know, 50-ish questions. Then we compare answers. That way it gives everyone a chance to think and no one's kind of like jumping at it and spoiling the answer, and gives everyone a chance to think critically. So that's one study method that I highly recommend, is if you guys can, form little powwow groups and just quiz the fuck out of each other. That really helps out for health assessment too. So kind of a long drawn out answer, sorry. Any other questions? All right, my cool kids. Everybody stay safe. Good luck on Thursday. And you guys let me know if you have questions in the meantime. I'll be around on Friday as well if you guys want to make an appointment.